Hi, everyone. Thank you for joining us for this autumn season's last Davis lecture. I'm very excited today as it features two of my favorite professors at the University of Chicago, and definitely some of my most impressive colleagues are here today. In a moment, today's discussion moderator, George Herbert Jones, Distinguished Service Professor at Crown Family School of Social Work Policy and Practice, Director of the Center for Health Administration Studies, Jean Marsh, will offer brief opening remarks and an introduction of today's presenter. Helen Ross, professor at the University of Chicago's Crown Family School of Social Work Policy and Practice, and the co-director of CHAS, as well as co-director of the University of Chicago's Health Lab, Harold Pollack. If you have any questions during the presentation, please type them into the Zoom Q&A pane, where the moderator and the presenter can answer questions following the presentation. I will also open the chat function for the presentation after the presentation. A recording of this presentation today will be featured on CHAS's YouTube channel, which can be found by searching for the Center for Health Administration Studies on youtube.com. And now Professor Jean Marsh will introduce today's presenter, Harold Pollack.
Good afternoon, everyone. I'm very pleased to be here today and to be introducing my distinguished colleague, Professor Harold Pollack. Many of you know him well as a highly decorated health policy researcher, a faculty member of the Crown Family School and Public Health Sciences at the University of Chicago, and a prolific contributor to op-eds, often published in the Washington Post. As Keith mentioned, he's also co-chair of the Center for Health Administration Studies. And I won't go into further detail because I'm told that by Harold that his mother's not here today, and so we won't reward her too much with the details. Today, Harold will be talking to us about policy challenges in intellectual and developmental disabilities.
Thanks, Jean, so much. Yes, if my mom was here, she certainly would have added, I'm sure, more details of my bio. That it's great to have a mom who's in your corner. I'm going to share my screen and see if and start my presentation. Can you see my my PowerPoint slides?
Yes, looks great.
Perfect. All right, thank you, Keith, for such an expert job running these seminars. So obviously, I got a lot to cover today. No one talk can cover this landscape, even from 50,000 feet. But you'll get my take on some key issues. And one thing I want to mention is COVID has served as a lens and as a mirror. It's a lens to view some of the policy challenges that we face when our society is under just incredible stress, from a pandemic. But it's also a mirror of our own generally unspoken social attitudes and organizational incapacities that really matter in the show don't tell moments when you're in a national crisis. We got a ventilator. Who are we going to give it to? I'll talk about the historical perspective on IDD, which on the whole, I would say is one of tremendous social progress, but also includes some significant failures. One of the most compelling, I think, to many of us here is the failure to address intersectionalities that are just really quite important in this space. I'll talk about the strengths and weaknesses of public programs, and in particular, the problematic choice architectures that they present to families and to individuals that create gaps and disparities at key junctures, such as the transition to adult services. And Don Moynihan and Pam Hurd produced, their work on administrative burden is just so classic and shows up in so many ways in this work. I'll note the necessity and the limitations of a deinstitutionalization framework. I'm not wild about that word, as I'll mention later, but the idea of deinstitutionalization as a service paradigm. And the political economy of a group that is socially valued, but that requires really expensive and costly services. And sort of the political and the economy kind of go in different directions in a lot of ways with this population. And then I'll also say some things about what I've learned about some of the challenges to our own policy analysis tools that sometimes fail to recognize the equal humanity of all people with analytic rigor. Okay, I want to acknowledge lots of people that I've worked with and funders, the Robert Wood Johnson Foundation Investigator Program, CHAZ, most recently the University of Chicago's Women's Board, Kenton Johnston, Marshall Chin, Fei Wen, and other co-authors, my wonderful colleagues in a new project with the Inclusive Economy Lab, Mike Levere, Jesse Orr, Guglielmo Bersesi, and Patricia von Hissenhoven. I'll show you some work by Rebecca Feinstein, now at UIC, that was one of my doctoral students, and we collaborated. Tony Sadler, Lauren Peterson, Ari Naiman, and my wife, Veronica Peroni Pollack, and my brother-in-law, Vincent Peroni, who lives with Fragile X syndrome and will show up in this story. And I also mentioned my SSA, Crown, and U of C colleagues who supported and still support my family in our caregiving roles. And certainly Jean is one of the most important people that I need to thank, because Jean and I were close colleagues when my mother-in-law died suddenly, and Vincent moved into our home, and we had challenges. But it's quite a blessing during COVID that I would be on Zooms with Crown colleagues and other colleagues at the University of Chicago, and Vincent, who was in our home quite a bit during COVID, would sort of wander into the Zoom, and my colleagues were just always wonderful. And there's a real lens into life when one faces significant family caregiving responsibilities, but also significant community and professional and workplace supports. So I just want to honor that. Okay. I should say this is a story that has many sad parts historically, but it's not a sad story in its overall trajectory. Many challenges, ironically, many of the challenges that we now face in public policy come from some of our successes. We've dramatically increased the lifespan of people living with intellectual disabilities, particularly Down syndrome. We have, to a tremendous extent, moved people out of often terrible large institutional settings into communities, but we now face a lot of challenges in community services. And I'll also mention that one of the chastening aspects of when one studies intellectual disability and one is a little bit more self-reflective is to realize in some ways people with intellectual disabilities and their families are in a privileged position relative to people with other disabilities that receive less public sympathy and practical support. And that is just so noticeable in many ways in American public policy. Whoops. So let me start with some opening anecdata, and I'll try to be disciplined about this. I was giving several years ago, I was giving a talk here at Crown for the incoming admitted students. And at the table where I was going to sit after I finished my talk, there was one man there who was wearing traditional Pashtun garb. He was the only parent in the entire room. The room was packed with students, and this man came with his daughter. And I was just thinking, like, what am I going to say to this man? Why is he here? What's going on? It's a little awkward because there's no other parents there. I finished my talk and I sit down, and he looks over at me and he says, "Did you know that Illinois ranks number 47 in the state of the states for developmental disabilities?" And it turns out he had come because he knew what I was going to talk about. And he has a son with a serious intellectual disability. He wanted to learn about services. And in particular, because he was from a traditional Islamic background, he was looking for services that offered proper food and so on for people, halal food and so on. And he was talking to people in the Orthodox Jewish community to understand how they had managed those challenges. And we had this amazing conversation. It turned out I had more in common with this gentleman than anyone else in the room. I'll mention another anecdata point, which was I was walking into the Olympia Fields Walmart with my brother-in-law, Vincent. And Vincent, he's 260 pounds. He likes to wear necklaces and stuff like that. And I was holding his hand. We were walking, and we passed all these teenagers who were having a ribald 17-year-old boy conversation, which I will not repeat here. And they look at us. No one says anything unpleasant. They wave. They're perfectly nice. All of the young people in the Southland of Chicago have gotten the memo they've all gone to school with kids who have intellectual disabilities, and everybody's really nice. When Vincent moved into our home, I was really worried that we were going to have negative encounters with local teenagers. People were just going to be obnoxious. That just doesn't happen. Another example, I took Vincent on vacation and we took a bus tour, a Hollywood celebrity mansion tour, and we get into it maybe 45 minutes, and all of a sudden somebody taps me on the shoulder. There was a Latter-day Saints church group behind us, and this guy says to me, there's like 25 of us and there's 2 of you, if you need to use the restroom or whatever, why don't you come join our group, and we'll watch your friend if we need to. And there's just an incredible amount of social support for people, especially because Vincent is very childlike in a lot of the ways that he presents himself. And I'll mention that raises some issues later on. And I'll mention one other issue, though, that brings up the intersectionalities. So I live in the Southland of Chicago. Vincent now lives in a group home in Crete, Illinois. Most of the staff members and most of his fellow service recipients are people of color. And I'm getting on my train one day in Flossmoor, and this wonderful person comes over to me selling me Tootsie Rolls. And they're selling me Tootsie Rolls for Misericordia. Misericordia is 35 miles north of where I live. It is where many of the wealthiest families in Chicago get services for their intellectually disabled relatives. And it has an endowment that's the many hundreds of millions of dollars. The service organization that cares for Vincent has an endowment of $1.5 million. Nobody's selling Tootsie Rolls for them. And the ways that so many of the best services for people with intellectual disabilities go to white upper middle class people is just so palpable, and it's an issue that we've not dealt with very well. Okay. Now let me jump to COVID. As I mentioned, COVID is a trauma, a lens, and a mirror. The most obvious thing is, as I'll get to, is that the intellectual disability community has faced an incredible mortality burden, and also incredible developmental and psychological impacts of just physical isolation, particularly in low resource setting. Imagine if you are living with Down syndrome and all of a sudden all the people around you are wearing masks, and you're sort of like, WTF is going on here? It is very challenging for people, and you can't see your family. Very, very difficult challenges. One thing that we found was very low vaccination rates in the direct care workforce caring for Vincent. In fact, an unvaccinated person walked COVID into the facility in a very frightening way that made someone very sick. And when surveys were done, a lot of the staff people said, look, I'm concerned about the health consequences of a vaccine. I understand why you as a family member, you as my employer want me to get vaccinated, but I have never been treated in a way that creates that relationship of trust and mutual trust, respect, and valuing that makes me think I should get this vaccine because you want it, even though I am concerned about it. And the poor treatment of the direct care workforce is just creates such a sense of moral injury among all of us. And it really showed up during COVID in many ways, one being that when we asked people to extend themselves and to get vaccinated, despite their personal ambivalence, a lot of people said, I'm not going to do that. And by the way, good luck replacing me, given the wages that are paid here and the work conditions here. And then I would say one final thing, which will come up, which was how the society responded when we had to ration genuinely scarce resources. There's a ventilator. Harold Pollack may need it. He's sick with COVID. Vincent Peroni may need it. He's sick with COVID, and Vincent lives with intellectual disabilities. Do we take into account intellectual disability in rationing that scarce rescue resource? So just in terms of some of the data, Gleason and colleagues in the New England Journal examined COVID mortality among 64 million patients in 547 care organizations. They found an adjusted odds ratio of 5.91 on mortality associated with intellectual disability. They actually would have found a higher odds ratio if they could have looked specifically at Down syndrome. And one of the things that there's some studies in Europe that are really quite concerning. Some of that is due to biological risk factors and comorbidities, but also some of it may have been due to implicit or explicit rationing of rescue care. And really, it is hard to overstate, especially early on in COVID, just how deadly COVID was, particularly with people with Down syndrome. Many places set up protocols to ration, to triage care. You know, there was a shortage of ventilators and other rescue resources. Washington State and Alabama actually specifically had proposals that would disfavor people with intellectual disabilities. Many of those places backed away from that when there was public controversy, but that was the initial move, and it came from rationing mechanisms that took into account quality of life, and that raised some very basic questions for people like me who research cost utility analysis and other methods. But another thing that was really striking was how physicians allocate their time. I don't know if folks saw last month, there was an article where just doctors talked about how they do not want patients with disabilities. They felt really bad about it, but they basically said, given the constraints we're operating under in the care environment that we are in, it's very hard for us to care for patients with disabilities. And this is not at all exclusive to intellectual disabilities, but that is certainly very pronounced. And everyone in that, everyone with a family like mine can tell you stories about that. And it's really striking, speaking as a Crown professor who teaches, Crown 456 policy analysis I've taught for years, which includes cost utility methods and quality of life assessment. COVID has really forced us to distinguish how do we allocate resources when we are making calculated risks about ourselves versus decisions about quality of life, where people with disabilities' quality of life is being judged by other people who don't have that disability. So, if I'm thinking, would I pay a lot of money for someone like me for a treatment that would allow me to live 2 more months when I'm in a coma? It's completely reasonable from an ethical perspective for me to say, no, I don't really think that's a good social investment. We have another issue where we have a ventilator that could give me 10 expected life years for Harold Pollack and 10 expected life years for Vincent Perrone. It is not okay that we disvalue Vincent Perrone's life in that trade-off because he lives with an intellectual disability. That is disvaluing his life. Now, I should say that there's legal constraints imposed by the Affordable Care Act and also Americans with Disabilities Act. Some of the legal constraints are well structured, some not. I can get a whole other talk about that. But there's no question that COVID has forced us to confront the equity concerns about disvaluing life-extending interventions for people with disabilities when we have genuinely scarce resources and making those trade-offs. Okay? I should say that my former TA and student, Anirban Basu, has just a wonderful way of dealing with this issue in a way that has analytic rigor and also has humane values that are being expressed through the dry language of mathematics. And Basu, Carlson, and Feenstra published this wonderful paper called Health Years in Total, which discusses how we can value interventions in these situations. And the basic idea that they came up with is, if you improve someone's quality of life as they themselves assess it, you take that into account. If you're extending people's lives, you take that into account. What you don't do is weight one person's life extension by their quality of life as assessed by other people and weight someone else's quality of life, by that kind of a yardstick. So if we had an intervention that cured Vincent's intellectual disability, that improved his quality of life as he assessed it, we count that. That gets counted in there, but we don't disadvantage him for the ventilator. Also, I'll mention some of the challenges that arise for public insurance. Medicare and Medicaid are the dominant payers for people with intellectual disabilities. Medicare, often through what's called the Disabled Adult Child Program, covers a lot of people. Medicare has some very punishing cost sharing, as we know, and it has poor coverage of key services that are pertinent to the social determinants of health. And I must say there's gaps and patterns in Medicare that don't always match my ideological priors, and I'll get that in a minute. Then there's the Medicaid program, much more comprehensive program, differs, of course, across the states quite a bit, has low reimbursement rates that really limit access. And we've all experienced that, including in our own hospital. And also Medicaid has long waiting lists, particularly for home and community-based services. They create huge challenges and effectively create disparities. And I'll get to that as well. Okay. So this is just a not very surprising graph that from some of the work that I've done with Kenton Johnston, Fei Wen, and Karen Joint Maddox. We just looked at ambulatory access and emergency department use among people with disabilities and others who are on Medicare. Not surprisingly, people with disabilities have more trouble getting care, are more likely to not have the primary care that we want them to be getting, are relying on the emergency department more often for things that would be ideally treated in other settings. And it just here's, for those that are interested, here's just the multivariate logit results, just really striking disparities between people living with disabilities and people not living with disabilities. And then the younger group, the IDD folks, really jumped out. Now, here's an unexpected finding that we had. We compared Medicare Advantage with traditional Medicare. And Medicare Advantage plans don't particularly want people with intellectual disabilities very often. They're more costly patients, they're more complex. Turns out Medicare Advantage plans do better than traditional Medicare for a lot of really important care needs for people with intellectual disabilities. And it's really very basic things. Did you get a colonoscopy? Did you get an annual cholesterol screen? Did you get your flu shot? Do you have a usual source of care? Are you able to see a specialist if you need that? It was really striking that Medicare Advantage, at least in the cross section, did better. And by the way, within Medicare Advantage, the non-special needs plans seem to do better than the special needs plans. And I think they're, I don't know that I can fully explain what's going on there and how much of that may be some selection bias, but things like annual cholesterol screenings and flu shots and things like that, just a tremendous difference. And it's basically Medicare Advantage plans. There's a set of very clear performance criteria that incentivize them to make sure that everybody gets their colonoscopy and so on. And I wish that Vincent were in a plan that had stronger financial incentives to make sure he got basic care. Another success, I joke with my students because of course, as a liberal Democrat, I'm the House conservative here at Crown. It turns out if you look at charter schools and you compare them to conventional public schools, that they may also do better, at least for certain segments of the student population, and when charter schools are properly regulated and funded. So Elizabeth Cetron did some really interesting work in Boston. This was comparing charter schools in Boston, no excuse charter schools in Boston, with Boston public schools, which are quite good by national standards. And what she found was that students at the margins of special education did better in the charter school than they did in general public education. I should say this is less true for other student groups. And I think there's very big opportunities for regulatory failures here towards people with significant disabilities. But it is strikingly true that with the proper incentives and oversight and regulation, sometimes these market-based models seem to serve patients with disabilities, students with disabilities better. Okay. Now let me switch gears and go into the history a bit. Okay. I do think it's really important, if you want to get a sense of our progress, it's really important to consider where we were not so long ago. One thing is eugenic arguments have been a persistent, usually unspoken theme in American society, present in social work, medicine, public health, and across ideological divides. 1899, the very first U.S. published case report of vasectomy in the United States notes the procedure's utility to sterilize chronic inebriates, imbeciles, perverts, and paupers. That's a quote from the article. 1934, an editorial in the New England Journal says called Sterilization and its Potential and its Possible Accomplishments notes Germany is perhaps the most progressive nation in restricting fecundity among the unfit. That's our profession. Intellectual disability was considered a private tragedy for the family and for the caregivers. And very, very often, more attention paid for the family and the caregivers than to the individual living with a disability. One of the one can have many jaw-dropping anecdotes. The great Eric and Joan Erickson, they had a son diagnosed with Down syndrome. They actually told their other children that this young man had died, and they institutionalized him, where he lived till the age of 22. Very limited schooling and care supports. Institutional care was often the only available supports, and the only way that families could deal with their caregiving challenges. So many of us from the vantage point of 2022 might say, why did families put their sons or their siblings into, the Illinois State Home for the retarded, or whatever the name was of the institution, which was often quite poor? The answer was that was the only place that was available. What we now consider community-based services essentially did not exist. And of course, there was limited lifespan and tremendous medical challenges associated with people with IDD. Here are just some folks at the wood shop working with. Another striking thing about these institutions is they had a surprising number of people with normal range IQs in there who had communication disorders and other things. And if you read the histories of some of these institutions, you would see they had residents who were keeping the books, who were writing memos, who were translating for the staff and running the place. It's just an astonishing story. One of the most striking things about this story is how the Second World War really is what brought tremendous change to it. Channing Richardson had this just profound piece called 100,000 Defectives. That was in the Christian Century. A lot of conscientious objectors were sent to state institutions, and they publicly described what they saw. And of course, this was during World War II. You can imagine the analogies that they presented. And although they were writing in their time, but it was really striking, Channing Richardson, for example, how he understood how many of the abuses that we might blame on the staff really reflected structural factors and work conditions, as this quote really brings out. And he brought a kind of human sympathy to everyone that I just find quite admirable, reading all these years later. I said, do not blame an ill-trained or crude attendant who harms a patient who is in this situation. They did not create that situation. The other historical turn of the 1940s was the emergence of women caregivers, middle-class mothers, for people with disabilities. There were a bunch of books that were written that were kind of like coming out kind of memoirs that people wrote. And the most famous of them was called The Child Who Never Grew by Pearl Buck. Pearl Buck was a famous Nobel Prize winning writer and novelist. And she wrote in the Ladies' Home Journal this piece about her own experiences. Hundreds of thousands of people responded to this. They were just, Ladies' Home Journal was just flooded with responses. She then published this best-selling book called The Child Who Never Grew. And I highly recommend, if you're interested in this field, buy this book and read it, and particularly read the foreword by James Michener and the afterword by Pearl Buck's daughter, Janice Walsh. I should say that this book is a real product of its author and of its times. And there's some things that are very sad about the book and that did not age. To say that did not age well is the understatement. One is Pearl Buck never mentions her daughter Carol Buck's name, and presented Carol Buck's disability as far more profound than they actually were. It turns out Carol Buck was a great athlete. She was a swimmer. She did all kinds of stuff. She enjoyed cooking and other hobbies. She was presented as the child who never grew. She was an adult with her own interests, and Pearl Buck also goes out of her way to emphasize that her family's of only the finest genetic stock and that there was no genetic related disability there. And in fact, it turns out Carol Buck, she lived with PKU, which was one of the first genetic disorders that was really well described and for which there are treatments. And so I recommend reading the forewords and the afterwords to this book. But of its time, it was quite important and quite a step forward. And I should say Dale Evans, who was a famous movie star, she wrote a book called Angel Unaware about her daughter and the experiences that her daughter had. And these two books made a ton of money. They were bestsellers, and the proceeds were used to help found what is now the ARC. It's quite a story. And I should say there's a whole genre of books that came out in that time. And John Frank was a Supreme Court clerk and a famous lawyer, and Charlotte Tucker was also a prominent person. And this was sort of the first time that people could really come out and talk about these issues. And those of you that have seen The Crown know that the royal family was not one of the families that talked about these issues. And yeah, there are some problems in their depictions. If you just look at this picture for a moment, boy, this is from Ladies' Home Journal, and you know, this beautiful white young child, no morphological issues, nothing going on that are often issues with people with intellectual disabilities. You know, this is not the way I hope we would present this issue today. You know, lots to be deconstructed. One of the striking things, by the way, was that this pioneering generation of maternal caregivers were among the most effective community organizers in American history. I remember Sarah Palin, she was chiding Barack Obama when she was in 2008, when she ran with you know, Senator McCain for president. And she said, I guess a small town mayor is sort of like a community organizer, you know, except that you have actual responsibilities. And I remember thinking, Governor Palin, the world's greatest community organizers are people exactly like yourself, who were moms who had responsibilities for children with intellectual disabilities. And these women began to find each other, and they were just amazingly effective in founding, you know, the collectivity that became the ARC. And they just had tremendous public status and political reach. There's a wonderful, James Trent, the historian, has written a lot about this history. It's just an amazing story, and it could come straight out of you know, a political organizing class here at Crown. So here's an example: Laura Blossfield from Bergen County, New Jersey. She's putting ads in the newspaper, and she's saying each parent can ultimately help his own child by doing something to help all children similarly affected. Therefore, I suggest an organization for all parents of mentally retarded children, one that might well prove to be the first chapter in a nationwide organization. 1949, a New York City housewife, you know, she's putting in an ad, you know, surely there must be other children like her son, other parents like myself. Where are you? Let's band together and do something for our children. You know, this is collective action in a most profound way. Images in popular culture have dramatically changed. If you think about that child who never grew, here's just the TV shows in the childhood of our Crown students. So this is Life Goes On. You know, there's a young man with Down syndrome as a character. This is Parenthood. This is a young man with autism. You know, protagonist. This is a young married couple. This is a wedding announcement from the Washington Post a couple of years ago. This is America's Got Talent. This young girl with Down syndrome wins the America's Got Talent thing. This is LA Law. One of the characters in LA Law was a gentleman with intellectual disabilities. Now, these are the cute and cuddly images. There's a lot that's not so great about this presentation, but wow, that's a big change in social attitude, especially when you contrast it with other things. So here's a wonderful paper that was done by Stanhope and Wong, where they looked at where are supportive housing units located for people with intellectual disabilities and for people with psychiatric disabilities. And by the way, if I ask many of you in the audience, is there a group home for people with intellectual disabilities in your neighborhood? You probably don't even know or care. Or you might say, oh yeah, there might be one. That's not our society's reaction when we're talking about homes for people with addiction disorders or schizoaffective disorders. So here on the left is the location of residential services for people with IDD, and the dots, the size of the dot represents the number of residents, and then it's where they're located. And what's striking is, and then over here, this is for people with psychiatric behavioral health challenges. And what's really striking is over here, you see all over the entire city of Philadelphia, on a small scale, you see just all sorts of facilities. Over here, it turns out they're larger. Each facility is larger, and they're also sited in communities that had lower income and were more likely to be non-white. There's a not in my backyard issue for these folks that there is not for these folks to nearly the same extent. And that's quite revealing. And here's, of course, popular cultural representations of serious mental illness. I hope we're making progress. Jane Pauley, there's things, there's certainly examples where there are positive representations, but boy, this is the Silence of the Lambs, where he's in a, the evil mass murderer is in a psychiatric facility. This is the person who shot Gabby Giffords. This is Homeland, I guess. Lots of very negative portrayals of people with serious mental illness. And one of the most awful things, of course, is whenever there's a rampage shooting and we see politicians saying we've got to deal with mental health in America, and somehow places around the world that have the same prevalence of serious mental illness, that have a better handle on guns, don't have as many rampage shootings. Let me also talk a bit about deinstitutionalization. And thank you, by the way, for everyone who's bearing with me. I know I'm talking fast and covering a lot of ground here. I appreciate your forbearance. I don't like the word deinstitutionalization in a lot of ways, but it is striking that intellectual disability is kind of the major success story for moving people out of large-scale institutions out into communities in a more humane way. And there were basically two arguments for deinstitutionalization in the 1950s, 60s, and 70s, it really took hold. One is a human argument, and the other is an economic and political argument. The human argument is moving people out of high-cost, inhumane public institutions, onto a more human scale. People would have better lives. The economic argument was we were going to save a lot of money, and we were going to use the money that we could save on these big institutions to provide community-based services. And it turns out that the human argument was right in a lot of ways, but the economic and political argument was not right. The political argument was wrong for one basic reason. The fact that one funding stream saved a lot of money did not create an immaculate conception of more money for another funding stream that would support the community-based services that were needed. And so there was a political mismatch in that. And I recommend Christopher Jenks's book, The Homeless, for more granular discussion of that. But the other thing is, it turns out that community care is more expensive than institutional care in a lot of ways. It's actually pretty cheap to warehouse people. And the point of deinstitutionalization was not or should not have been to save money. And in fact, it costs more money to provide people with better care, and successful policy change required powerful constituencies that could monitor implementation, channel resources where they need to go. And that actually happened in the intellectual disability space, because the intellectual disability community is a very powerful and socially valued constituency. It did not happen in some other areas where there was just less political influence and more social anxiety about the population. I should also mention that deinstitutionalization creates an enormous unfunded mandate on family caregivers. And Sarah Sabatka is really one of the people that has really taught me about this. That, if you think about people who are moving out of an institution into the family home, or they are now in the family home and 50 years ago they would have been in an institution, very, very often there's a woman in the home who is doing the work of caring for that person, whether it's their behavioral needs, their physical health needs, whatever the needs are. Very often that person has made enormous sacrifices to do that. When Vincent moved into our home, it really it essentially ended at least that phase of my wife's career. And also, there's other unfunded mandates on family caregivers that we might more easily miss. Group homes, the real name for a group home is a community integrated living arrangement. That's essentially the common sense word, group home. We really rely on family caregivers to monitor the quality of CILAs and what's going on inside these places. And that's really a challenge for families as well. And I think we oversold what a free lunch deinstitutionalization would be. And that's particularly challenging because people are living a lot longer than they used to. So the median lifespan among people with mild or moderate intellectual and developmental disabilities is essentially the same as the rest of us. It's a little shorter, but it's dramatically increased. And that means that most adults living with intellectual disabilities are going to outlive their parents and very often their primary caregivers. Right now, about 1 million Americans with intellectual disabilities live with a caregiver over the age of 60. Most of those caregivers do not have a plan for where their loved one would live and what's going to happen if they can no longer provide the care. And we also see tremendous wait lists for services, for home and community-based services that relate to this. 589,000 families in the United States, according to one estimate, are now on wait lists for Medicaid HCBS, for IDD services. By the way, 5 states account for 80% of it. What they really should have said is Texas accounts for more than half of it. 323,000 out of that 589,000 are estimated to live in Texas. Ohio, 68,000, Louisiana, 27,000, Florida, 22,000, Illinois, 19,000. And in one recent study, there's a 60-month mean wait time for IDD services, and it's very often longer in a lot of states. And so just to switch gears again, one of the things that I'm quite interested in is how families manage this and how the choice architecture that we present to families both deserves families and creates predictable disparities where families like my own are much better equipped to gain access to services that other families may actually need more. Okay. So, and I should mention here, this is a paper that Rebecca Feinstein and I published in Social Service Review in 2016. And thanks, by the way, to Susan Lambert. Our initial draft of this paper was quite problematic, and Susan worked with us because she thought this was an important issue. And I'm so grateful to Susan. You see this title, "We Don't Have a Plan, We Should Be Working on a Plan." And here we interviewed caregivers who were caring for individuals with Fragile X syndrome. Okay. So this goes back a ways, but we did focus groups and we did open-ended phone interviews totaling about 40 people, and they were all getting care at a Fragile X clinic. Okay. I should say we probably would have found somewhat different answers if we had looked at other intellectual disabilities. Our sample was really tilted towards white and above average incomes, as you'll see. And we did not talk to the people who were actually living with Fragile X syndrome, whose perspectives might differ from those of their caregivers. So some definite issues here. Just who we talked to, you can see 35 women, 5 men we interviewed, almost all were moms, and 35 Caucasian. So, you know, what can I say? They're, maybe Jean, if you could check and see, I see there's some things in the chat. If you could just make sure there isn't a clarification question that I should answer, or Keith, if you could let me know. Most of the people that were being cared for in this study were young men living at home, most of whom were under 30. And we just asked what was going on, you know, and how people were planning for the future. One thing that we found that was quite striking was the prevalence of safety issues. In a national survey of parents caring for mostly their sons living with Fragile X syndrome, about a third of them reported being injured by their sons. And when that happened, it was usually a regular occurrence. And Don Bailey and his team did that work. And we saw that in our sample. Some of the women that I talked to, you could see they had black and blue marks. And so respondent 306, she's not aggressive or violent just for the sake of it. I know what triggers it. I spend the vast majority of my days working around knowing how to prevent something like that from happening. Another lady was pushed down her stairs accidentally, breaking a rib and puncturing her lung. And although she admits that her son is a safety risk, she's very wary to send him to a residential placement for some very simple reasons. Basically, the only places that would take him were places that would take other young men with the same behavioral challenges. And she was really scared. Like, what would it be like for my son living with other 25-year-olds who have these behavioral challenges? I'm afraid he's going to get hurt. I should say we have not had those kinds of moments in our home, although we have had some challenges, but nothing like the ones here. And then my wife made it quite clear to me. One day we're sitting over breakfast and she said, never call 911. I really don't care what my brother's doing. Never call 911. Having a police officer wander into our home is not going to improve anything. And one of the things that I highly recommend, and I thank Leanne Davis from the ARC for pointing me to this, is there is a growing body of work and webinars and resources to help police interact more effectively with intellectuals with developmental disabilities. Some of it is just very, very basic but critical stuff. If you say to someone, do you hear voices? People with intellectual disabilities are very concrete. They'll say, yeah. What they mean by that is, I can hear you. What very often the officers interpret that as, oh, this person's having a psychotic experience. No. There's many ways police can raise their game in this area to help people with intellectual and developmental disabilities, but also to help other people as well. Here's a story, by the way, if you want to, I'm going to tell the next 3 minutes, I'm going to describe a tragic situation. And so if you don't want to hear about a tragic situation that resulted in a death, please feel free to mute your line or to get a cup of coffee. And many of you, by the way, have seen me give other talks where I talk about police first response to people with behavioral health crises. This is the kind of case that is very pertinent to it. Ethan Saylor was a young man in Maryland who went to the movies with his 18-year-old caregiver, and he goes to the movies, and the movie ends, and he gets very agitated. They walk out in the lobby, and he gets very agitated, and the caregiver actually calls his mom and says, "What should I do?" And his mom says, "Why don't you get the car, bring it around? I'll come down, and we'll see how we can, maybe he'll calm down, and we can figure out what to do." Young woman gets the car. While she gets the car, Mr. Saylor goes back into the movie theater and sits down in his original seat. He's quite agitated because he wanted to watch the movie again. And you're not allowed to do that. And the manager shows up and he starts jawing with Mr. Saylor, and it escalates. And the young woman, the caregiver says, "Hey, please don't get in his face," etc. Manager he's not going to listen to some 18-year-old girl telling him how to do his job. He calls mall security, who are two off-duty sheriffs. And again, the young woman tries to intercede with them. They ignore her. Mr. Saylor's mom arrives. And I should say that the sheriffs tell him, basically, if you don't come with us, we're gonna remove you and arrest you. And his mom arrives just in time to find that they pulled him out of the chair. They were struggling with him. He ended up underneath them on the ground, and he asphyxiated. He has Down syndrome, and you can see by he's a powerful man. You can imagine that they had a real struggle. He was being restrained face down, and he died. I do not believe that those sheriffs in any way, I'm sure they felt horrible. But if they had just followed basic principles of de-escalation, of time and distance that we teach officers when dealing with people with serious mental illness, this would not have happened. I should say, by the way, direct care workers need those same kinds of de-escalation trainings. One of the things that's really striking in SILAs is the way that the staff sometimes threaten the residents that they'll call the police if they don't behave, and they use that as a method of behavioral control. And one of the stories that is most poignant to me, there's a gentleman lives in a SILA, goes away to his group, and this is where I heard from Bruce Davis, who's an expert on this stuff. Man goes to his day job at his sheltered workshop. While he's away, the staff of a SILA give away his dog. Guy comes home, his dog is gone. He flips out. The staff call the police. The police come, and they say, "Well, where's the dog?" And the staff become irate at the police. And the staff basically said, "That's not why we called you. Basically, we called you to make him behave." And the idea that the police would actually try to mediate and understand why the guy was upset, that was not what the staff wanted. And one of the challenges that we have in safety is the low quality of services, poor working conditions, and poor training creates real risk factors for both staff and resident aggression. Vincent, my brother-in-law, has been assaulted a couple of times. And one time we think may have been a staff member. But in another case, he went into someone's room and he picked up a toy that was on the guy's dresser, and the guy got very upset. And the other resident took off his belt and he started to hit Vincent with it. By the way, this guy was very small. Vincent's a very large man. Fortunately, Vincent stood there. But when I heard that story, what really made me want to cry was, where did this guy learn how to take off his belt? You know, that was not a spontaneous behavior. The other thing that's really striking is thinking about life course issues and the way life course issues make such a difference. And there's such a mismatch between the life course of individuals and caregivers and available services. You know, especially in recent years, young people receive a relatively rich array of school-based services and entitlements. You know, many of it's coming from IDEA and from lots of other legislation that folks are quite familiar with, much less available for adults. And people face what Sam Bagenstouse has called the disability cliff when they cross between adolescence and young adulthood. And of course, that transition point between adolescence and young adulthood, that is so different for so many different people. Many of us have many different transitions and restarts, both as young adults and also as caregivers. People change jobs, they retire, they get divorced, they have caregiving needs from other family members, and adult disability systems are very poorly designed to deal with those things well. Here's some, here's just some randomly selected articles that really break this out. And so Rebecca Feinstein and I talked with people about how they manage these challenges. So when we talked to people, we found it was sort of a behavioral economics nightmare for people. Behavioral inertia and many obstacles prevented caregivers from really having sensible transition plans. My biggest concern is that we have a plan in place for that day or that event that causes us to be unable to care for him. We don't have a plan. We should be working on a plan. I don't want him to lose everything all at once. I don't want him to go from living at home with a parent to all of a sudden somebody has to place him somewhere else. Somebody has to find support for him. And then our 103, our motto is to live one day longer than our kid, just one day longer. Wow, that was hard to hear. And we actually divided long-term planning into key domains: caregiving and housing, legal guardianship, and financial planning. Only 10 of our 39 caregivers really had a fully concrete plan for all these domains. Whoops. By the way, I should say that Danielle Boyce and her colleagues were examining situations for people with Dravet syndrome and found almost identical quotes. It was just astonishing, and also found tremendous disparities that that basically it's up to parents to figure so much of this stuff out, and more affluent parents were able to do that in a way that other parents were not. And I highly recommend Dr. Boyce's work and others in this. Here it says, our families need to be told to get on the waiver list as soon as possible. One of the things that we found was that some of our respondents had their kids in Winnetka at New Trier High School, where they had excellent transition planning. And then, of course, I had people in Chicago public schools and in the less affluent suburbs where just nothing like that was happening. And there's nobody doing anything bad in these well-resourced schools. They were doing a lovely job helping families, but wow, that really deepened the disparities because people in the better school districts were getting better services. And those of you that are familiar with the scarcity literature and behavioral economics would certainly be familiar with that. And one of the ironies of the situation that we found was that many services are allocated on the basis of a crisis. You can move ahead in what's called the PUNS list in Illinois if you have a crisis. Well, the crisis is not a self-defining thing. It's something that you have to present a narrative that fits the groove of a crisis. And if you have access to good advice, you can present that narrative in the most compelling and accurate way. And not that you're going to lie about it if you're a privileged parent, but you're cued into how you communicate that in the most strategically effective way. Okay? And so one of the things that we found was a real Moynihan and Hurd kind of administrative burden nightmare where complexity creates disparity. That we found that our more advantaged parents were presenting more compelling claims than less advantaged parents were able to do who faced the same challenges. Very often our more advantaged parents had hired professionals to help them navigate arcane program rules, fill out the paperwork, to just know that things existed that they could access. And the irony was, of course, many of these more advantaged parents had a bigger safety net from their own personal resources that made it less of a crisis than the parents that were behind them in the queue. And so one of the moments in our focus group that many of my colleagues who are on this Zoom have heard me tell this story before, our most affluent respondent lived in a mansion in the north side of Chicago, and one of our least affluent respondents interacted. One of our respondents who lived in a low-income Southwest Chicago suburb was caring for her 19-year-old son who used a diaper. She would bathe him. She gets a call from someone at the state of Illinois saying, "Are you in crisis?" And she says, "No, I'm not in crisis, but I could use some help." This mom across the room, most affluent respondent, she says, "No, that's not what you say. You have to learning how to be in crisis. You need to have the worst crisis day you've ever had in your own mind and be in crisis. Someone told me how to be in crisis and I was in crisis." And she said, you just tell them, I can't do this anymore. It's ruining my marriage. I may just have to take him down to the emergency department and just leave him there. And by the way, this was completely told in a loving way to try to help this other parent, to say, this is how it's done. But imagine the sense of personal security and impunity that you'd have to present that kind of a narrative to an agent of the state. This other woman, she had other kids. Yeah, you're going to say, I can't take care of my child. I may just abandon my child. That you could just say that to someone. The sense of confidence that involves, it embodies privilege in such a profound way. The other thing I'll mention is the SSI countable asset limit, which creates so many problems for families. And it's probably the single stupidest feature of American disability policy. I cannot believe that we didn't fix it. I should say this asset limit was last raised in 1989. The 1972 limit would be $10,658 today. Just a huge missed opportunity, and creates also a lot of unintended consequences. One thing is that it forecloses legitimate paths to saving and investing, and it encourages families to do illegal or unwise workarounds to achieve legitimate goals. So I'll give you an example. So you have a 78-year-old parent named Shirley. And she's got two kids, Susan and Sam. Sam lives with an intellectual disability. Susan does not. She's a teacher. So Shirley says to Susan, "I'll tell you what I'm going to do. I'm going to leave you my home, but just so you know, half of my home is really, I want that to be resources for Sam. But I can't put anything down on paper because he can't have more than $2,000. Well, then Susan goes and gets divorced, and she and her partner are fighting over the value of this home. And of course, there's no paper trail that says part of this money is Sam's. And Sam has no way. And also, Susan also has now a lot of control over Sam's life that Sam may not want because she's controlling a lot of the resources. And so there's lots of ways that this asset limit creates unintended consequences for people. Now, there are workarounds for it that families like mine use quite a bit. Family special needs trusts, and I'll get to something called ABLE accounts in a second. I once got on a Facebook group for people with intellectual disabilities, and I asked people how they manage this, and I got these amazingly fabulous emails back from parents describing how they manage these complexities. One was from a Booth School graduate who is now a successful financial entrepreneur. They were all from very upper middle class people who knew how to deal with this. Now, there have been policy innovations to try to help people, the most recent being something called ABLE accounts, achieving a better life experience. And that really illustrate this point, with an exclamation mark. So here's so ABLE accounts, you can put money in. It's a lot like a 529 account for those of you that have had college accounts. You can put up to $16,000 a year in it. And you can basically use the ABLE account funds for almost anything that promotes personal development, independence, and well-being. You can buy clothes, you can go on vacation, you can use it for transportation, housing, lots of stuff. And by the way, if you have a job, you can put money, you can put your paycheck into that if you're say a greeter at Walmart and you live with an intellectual disability. And the first $100,000 that you have in the ABLE account does not count towards any of your benefits. If it gets over $100,000, your SSI cash benefit is suspended, but Medicaid continues. And for many people, Medicaid is the key thing. There are less than 2,000 active ABLE accounts in Illinois. I'll let you guess where those accounts are located. I'm not going to show the map of it, but I can tell you that they're in the most affluent zip codes in Illinois. And Mike Guglielmo and Patricia, I really thank you for the collaboration that we had, and Jesse Orr on this work. And I should say, nationally, maybe 3% of people eligible for ABLE accounts have them. There's no ABLE accounts essentially in the south side of Chicago, the west side of Chicago. So these interventions are really designed to fit the groups of middle-class life. And they're very advantageous to families like mine, partly because we have similar accounts for our kids' college, for our own retirement. We often interact with financial professionals, and we're the people that have these. Right? And the people who run the ABLE program they're really trying hard to broaden their reach, but it's very hard. This is page 2 of the disclosure documents you get to. If you just click on the website for the ABLE program and you want to set up an account, this is page 2. Now, for someone like myself who's sort of obsessed with personal finance, a lot of this looks very familiar. If you have a Vanguard account or something like that, this looks a lot like what you're going to see. A lot of other families are going to look at this and they're like, what is this? And I got to send this to the NSA for decryption. Sort of look down here at all this language. It's very forbidding. And people are, am I going to jeopardize my loved one's benefits if I open this thing? And so the choice architecture is very, very poor for these programs for most families. Imagine if instead, as a policy, the state of Illinois or the U.S. Treasury opened ABLE accounts for everybody who was eligible, and maybe put in $50 a month or something like that into the accounts, and to help you manage the paperwork. And families could contribute as well, but the government got you started and created a legitimate account for you. Think of how many more families would be able to take advantage of this and would even just know that it existed. And when you think about $50 a month, that is nothing compared to how much Medicaid is spending on these folks, how much other public programs are spending on these folks. But this is something that actually would improve people's independence in a very concrete way and allow people to get out of that straitjacket of that $2,000 accountable asset limit. We could do a whole lot more to provide counseling for people, to help people manage the wait lists. And I won't go into that now, but imagine that on the caregiver's 60th birthday, there was an automatic appointment that said, hey, that's a caregiver transition appointment. What's your plan? How can we help you with your plan? Because, families, of course, these are very difficult conversations. You can imagine why we all want to put them off. It's something that has to happen. And I would say, finally, how important it is to end the institutional mindset in America. In many ways, we have really moved people out of institutions into the community, but we have not ended the institutional mindset in a lot of ways. If you look at the lives of people like my brother-in-law, who now live down the street in a 5-bedroom house, their daily lives are no more socially integrated than someone who's living in a well-run dormitory style institution. If you say, young person gets up in the morning, they get on their little jitney, they get with other people with intellectual disabilities, they're taken to their day work experience. They come home at the end of the day, everyone they interact with is someone with an intellectual disability. They're not living any more of an integrated life than someone in a well-run institution might have run. And so we need to end that institutional mindset in America. And with that, I'm going to end my talk, and I look forward to the conversation. Thank you. So Keith and Jean, shall I just go to the chat and field them, or how should we?
Yeah, go ahead. I didn't want to interrupt you, but Rebecca Feinstein posted earlier. She thanked you for acknowledging her, so she is on the call today. And then Ellen Bannister had a comment early that there was a 13-year wait for Medicaid waiver services in her state. So I don't know if you want to start with Dr. Emsall. He
Dr.
was-
Masal knows, no, he's forgotten more than I know about everything that I've just presented. He's, noting that the community supports are dramatically underfunded, and how that, and the ways that that makes it hard to have people who are properly trained, and loan forgiveness and other tools should be used more aggressively. I completely agree with that. And I just want to thank you, Dr. Masal, for the services that you've done. There,
Harold,
yes.
may I just
Oh,
jump in
no,
here
oh,
and
please.
summarize? There are several of the questions in the chat that are really about how can I learn more? How can I use this incredible presentation in my own work? And I'd like you, I mean, obviously this presentation will be available, but what is the next step on getting the word out and getting whatever progress we've made better utilized?
I think there's a number of things. I think Dr. Masal and our colleagues across campus, Sarah Sabatka, others are excellent. UIC has a wonderful set of resources as well. And if folks want to reach out to me offline, I will be happy to share the resources that I have. The ARC is, of course, a critical resource. And there's many ways to tool up. There's no one path that is perfect, but there's many ways, and I'd be delighted to interact with people offline.
That's great, thanks. You want to carry on through the chat?
Or would it be easier if you were to, maybe
No,
more clear if you
well,
check?
you can go ahead.
There, so Mackenzie Brogan asked a really good question. Are the same issues seen with medical first responders and paramedics as with police? And do firefighters, are they questioned? That is such a great question. The answer is horrible training and in fact, there's many ways that all the issues that we worry about with police show up with every other kind of responder. And there's some very basic things. One of the most basic things is when someone is, if we're thinking about crisis response, if you come onto the scene and someone is behaviorally dysregulated, you are not going to know why they are dysregulated. They could have an intellectual disability. They could be intoxicated. They could have a serious mental illness. You're not going to know that. And moreover, trying to figure that out is not even necessarily the most useful thing, because the basic principles of time, distance, and cover are the same for a very wide range of what's going on. You give the person some physical distance, you give them time to calm down, and you try to get other people to help, ideally someone who knows the person who could talk to them. One of the sad things about Ethan Saylor is extricating someone from a chair is one of the most dangerous things that you can do for yourself and for the person that you are grappling with. Once you put your hands on someone, it's now a random thing. And it's very, very often when you're dragging someone out of a chair, you basically end up grappling on the ground and someone ends up face down with someone else on top of them. And if they had just sat there and waited, that situation could have been resolved perfectly. Or I shouldn't say perfectly, that's an oversimplification. Now, I should say one of the real challenges, by the way, in addition to that, is follow-up. The other challenge is if the police F up, we all talk about it on seminars like this. If no one ever follows up when someone has a behavioral crisis, very often that's overlooked. And some of the work I see that Arissa Ruano was on the chat, and some of the work that my health lab colleagues and I are doing with Chicago's CARE program. We're trying to improve some of those follow-ups. There's a lot that we could do there. There also Leanne Davis from the ARC put some nice things in the chat, so please check those out. There, let's see.
I think the next question is Rebecca's at the bottom.
So beststudy.info is let's see. There, Rebecca Feinstein has some nice information about beststudy.info is a new PCARI funded resource that is available. So I see there's something in the Q&A. Can you speak to the role of the Olmsted decision in both getting people with IDD in the community, but also stipulating that community-based care should be less expensive than institutions? Yeah, Olmsted is the most important Supreme Court decision that most people have never heard of. It was such an incredible advance that gave people the right to be living in the least restrictive environment that meets their needs. Now, I should say that the idea that community-based care should be less expensive, that just should never have been, we should never use that rhetoric. And by the way, we are very tempted, those of us that want more humane services, we're very tempted to say that they save money, just like we are very tempted to say prevention saves money. I really think we should avoid that framing. By the way, Holly Lechniak puts in a really important point. Smart 911 is a nice resource that's starting to improve communication. I think that's just so critical. That, just you can register in Smart 911 that just says, my son has autism. If you're called to our house, please do not turn on the sirens. Or, here's just an issue, or it could be things like we speak Vietnamese. There's a lot of things that I'm a huge fan of Smart 911. Also, Holly asked, am I aware of efforts at the federal level? There are some bipartisan efforts to try to raise the SSI asset limit. It seems like both Democratic and Republican senators from Ohio have been really on this one. I don't know why we haven't done it. It's expensive a little bit, but it is absolutely ridiculous that we still have this $2,000 asset limit, particularly when more privileged people can find ways to get around it in many of the cases. Although I must say the ABLE accounts, you have to have a disability whose age of onset is lower than age 26. So it does not, so the $2,000 asset limit is still punishing towards many other people with disabilities who cannot avail themselves of the ABLE accounts. And Leanne Davis put a really important link in the chat about people with IDD in the criminal justice system that I highly recommend. The ARC is obviously a key resource there. Other questions or chat entries? Have I exhausted everyone?
I think you were proficient answering everyone. Jean, do you have any questions or additional comments?
You haven't exhausted us. You've inspired us. I really appreciate this talk. It's excellent talk. We'll make it widely available. And I really appreciate your giving the Michael Davis lecture today, Harold. Thanks very much.
Thanks so much, Jean, and thank you for supporting me and my family when we face some of these challenges. And I wish that everyone in America had a job like I have at Crown, where I get the kind of support from my workplace that makes it possible to be a caregiver. And that's something that I think about quite a bit.
You're a generous man, Harold. Thank you. Thank you all for coming. Bye now.